Hello, everyone. This is Howard from ICN, and I'm delighted to be joined today by Dr. Rafael Lozano, who is one of the lead authors on a very significant new report on the global health workforce from the Institute of Health Metrics and Evaluation at the University of Washington School of Medicine. You all know that when we worked on the State of the World's Nursing Report, we identified a shortage of 6 million nurses globally. You know that ICN has been monitoring and reporting on the impact of the pandemic on the global nursing workforce, and are very concerned that that shortage may have got worse over recent months and over the next few months and years as well. The report from IHME is some fresh analysis and some fresh thinking and projections on what the scale of the global shortage of healthcare workers could be. Dr. Lozano, thank you so much for joining us. Thank you for your work on this report. Please do tell us what some of the headline and key findings from the latest report are.
Thank you very much, Howard, for the invitation, and it's my pleasure to speak to your big audience. We are releasing a publication in The Lancet regarding a big study of human resources for health. We incorporated 204 countries and territories for a time series from 1990 to 2019. And we found that in total, we have 154 countries have shortage of nurses and midwives. And that represents in number of nurses and midwives around 30.6 million, different than 6.4 million of physicians. This study also reveals that there are big gaps. If we take regions, the fold is 10 times. If we take countries, this increase huge. Let me just tell you that in the case of, if we compare Norway with Somalia, the density of nurses and midwives, the gap is 69 times.
We've been very aware of the inequality in the distribution of nurses right the way around the world between different countries and different regions. But the shortage number that you're highlighting of 30 million is, significantly bigger than the 6 million number that many people listening to this will be aware of. And I think your shortage for all healthcare workers at more than 40 million is also significantly more than the 18 million that we've been aware of before. Tell us a little bit about the reasons for the differences in those numbers, please.
Sure. We have used a different standard to estimate the expected value. This is an external indicator of the density of health workers. But as we know, the health workforce is closely related to any health outcome. In this case, we use effective universal health coverage, not only to answer how many people are receiving X or Y health intervention, also how much health are they gaining when they receive the intervention. That is the big difference with other methodologies. Our definition of universal health coverage is different from definition of WHO and the old definition when they calculated the shortage of 6 million. So when we do this analysis, we capture more inefficiencies in the countries and the performance of the countries because our aspiration is higher. We aspire 80 to reach 80 in the universal health coverage index And that threshold not only captures shortage of human resources of health, also the excess of personnel, which implies more concentration than we will expect. I was expressing the example of Norway and Somalia before, and now I can tell you that 50 countries in the world don't need more nurses. In fact, 12 of them, the majority are high-income countries, concentrate 2 million more nurses than they need. So that's the kind of gaps that we are capturing in this study.
So because you've used a more comprehensive definition of universal health coverage, of access to health services, I think the index that WHO had used was around 30 and yours is around 80. That accounts for the difference. With the 6 million and the 18 million, then the 6 million represents about a third of the 18 million shortage. But with your numbers, with 30 and 40 million, then 30 million nurses represents more like 2/3 of the overall shortage. Would it be fair of me to say, Dr. Lozano, that higher threshold for access to healthcare, it's actually incorporating a lot of healthcare that would be nurses' work, that nurses would lead on? Is that a fair assumption for me to make? And would there be any examples of nursing work, perhaps, which might be included in your definition, in your analysis, but haven't been in the WHO work up until now?
Well, thank you, Howard. The question is quite right, and it's fair, your assumption. The health system performance relies heavily on the number of health workers, but the mix or composition of the health workforce is also relevant. The share of health workers who are doctors versus nurses versus other occupations determines how the tasks are distributed, and the composition or mix of types of health workers in a country can influence how health systems are organized. Globally, there are 2.3 nurses for every doctor in 2019, with more than 90% of countries employing more nurses than doctors. Our data show that the mix of health workers differs substantially across countries. Japan, for example, had 5 nurses for every doctor, while in Lebanon, there was nearly 1 nurse for every doctor. The mix of health workers varies even among countries with similar levels of universal health coverage. The example that we have is Bangladesh and Philippines. Both are lower middle income countries and the same level of UHC, around 54. However, these health systems perform similarly, employing different ratios of doctors to nurses. Bangladesh has the rare health system with more doctors than nurses. Hard to explain how they work. And in the other side, Philippines, 5 nurses per doctor. Maybe, and we know the story of Philippines that not only produce for the same country, also export a lot of nurses.
I mentioned at the start that we've been tracking the impact of the pandemic on nurses, on healthcare workers generally. Been very concerned about the physical, the mental health toll that the pandemic has taken. At the recent World Health Assembly, some of the data presented suggested that the global shortage may have reduced a little. It may have improved a little bit, but we were concerned that was relying on data before the pandemic. What's your view and the author's view about the impact that the pandemic has had on nurses and the global healthcare workforce? Should we be concerned that might result in in more people leaving and increasing shortages?
It's important to tell you, Howard, that the answer or your questions is going to, we have to wait a little bit because we stopped in 2019 the study and we already don't know the impact. In fact, I can offer for the future, we are working hard exactly in that, discovering the COVID impact directly in the health and indirectly with the people. Second, splitting by sex the whole health force, because we know the importance of gender inequalities in the field. And also we are expanding the cadres. Then we analyze it because we analyzed 16 cadres in total, but we published only 4 that are connected with the SDG 3C.1. So at the end of the day, the answer to your question is not complete in our study. However, I can give my own point of view with all the risk with my team, because I have read this big paradox. It is, we need more nurses, but nurses are rethinking carefully what is their role in the health system, what is their capabilities related with the high tech, what is their responsibility. So my point is, we need to listen more what they want. We need to listen more what they can do. It's not just matter of salary. Of course, money matters, but it's more how they think about their role in the health systems. And we need to listen, because that's the only way that we can empower nurses in the health system. The health system is physician-centered, and always we speak about physicians. And I am a physician, and I can tell you, without nurses, it's impossible to run any health facility. So I think there are surveys that different agencies are applying, and I'm sure that you are doing your own work, trying to understand what the nurses are thinking related with the big impact, not only in the physical health, also in the psychological health. And what is the coming future? Because at the end of the day, the call that you did was invest more to improve the education of nurses in order to keep them not only happy, to keep them useful for the health of the world.
We couldn't agree with you more strongly, Dr. Lozano, that retention is as important as recruitment, and all of those issues you've mentioned about listening to people feeling valued, respected, the gender equity issues, the flexibility at work, as well as pay and staffing levels, are critical to holding nurses in the profession. And listen, we're very grateful to you and your colleagues for shining this light on nursing as well. We firmly believe that in addressing many of the future health challenges that the world is facing, nurses have a really key role. We will be keeping a very close eye and interest on your next work and your next study. I hope very much that we can talk again, and because we'll be very interested to share the next work that you do with a global nursing audience. My thanks to you, and please pass on the thanks of ICN to the whole of your team as well for the work that you're doing and the report that you've put out. It's been a pleasure to talk to you today, and we will look forward to staying in contact. Thank you very, very much.
Thank you, Howard, for the invitation, and my congratulations for all the work that your institution, the international, the council are doing to support all the hard work for nurses. Happy to help anytime.
Thank you.